One nice thing about liver disorders is one of the signs that accompanies a malfunctioning liver is jaundice. So, jaundice is a sign of a disorder. All it tells you is that something is wrong with flow of bile, and bilirubin is building up in the body. So, this could be caused by a liver disorder, by a gallbladder disorder, and we're going to go through the different types of jaundice. There's three, and understanding again the normal function that bile plays in the body with excretion of bilirubin will help you to distinguish jaundice as a sign and symptom and start getting you oriented to using this almost like a playbook to help determine what's wrong with an individual. So, starting out, jaundice can be characterized by different types, but essentially, it's dealing with a high level of bilirubin in the blood. So we'll start out with just hyperbilirubinemia, excessive bilirubin in the blood. Bilirubin levels above about zero point 0.3 to 1 mg per deciliter are classified as hyperbilirubinemia. When you get to jaundice, we start to see the yellowing of the whites of the eyes and of the skin at levels of bilirubin above 2.0 mg per deciliter. So this is something, when you see jaundice, it's a physical display of yellowing. So it tells you that something, again, is wrong, liver related, but not what. But what you'll see is yellow brownish skin slash sclera, the whitish parts of the eyes. And the three possible causes are going to determine also the names. So first of all, we have prehepatic jaundice. So that means before the liver. And that has to do with major breakdown of red blood cells. So a large amount of red blood cells are being broken down. The second cause is hepatic jaundice, so it's a problem with the liver itself, in that the liver cells, the hepatocytes, possibly are not making the bile as they need to, or the liver itself cannot conjugate bilirubin. So it could be a failure in the hepatocytes function in those two ways. The third is called posthepatic, in that the problem is after the liver, and this most commonly has to do with stones impacted in either the bile duct, the cystic duct, or the sphincter of Oddi. And all of those are important when we go through the anatomical distributions and thinking about whether or not we would see jaundice. So let's go through these, the first being prehepatic, also referred to as hemolytic, associated with the lysis or breakdown of red blood cells. So excessive breakdown, we know that red blood cells are broken down into component parts and we get the release of hemoglobin, which is then broken down into bilirubin. So when there's a large amount of hematomas being broken down, perhaps after an injury, after excessive bruising, the excessive bilirubin in those cases can overwhelm the liver's capacity to clear the breakdown of red blood cells at bilirubin at a normal capacity. So you see the serum levels of bilirubin start to rise. And remember, the kidneys can't really pick up the slack because they can only excrete the conjugated form of bilirubin. So it still has to make its way to the liver to undergo this conjugation reaction with glucuronic acid so that it can be excreted from the body. And only 10% is excreted as urobilirubin. The rest is going to be through the feces. So this is a pretty straightforward form, hemolytic, and it's called prehepatic because this is a problem that comes before the liver. It has to do with a large amount of red blood cells being broken down. Then we have hepatocellular or hepatic jaundice, which means physically the cells of the liver are not working at a level that is necessary to clear the bilirubin from the body. So this could be due to a variety of cases. You see a number of them listed here. So it could be due to these different viral hepatitis cases that we'll see. Different drugs can cause this, cirrhosis of the liver cancers. So something is affecting the liver itself. So either the liver cells are not taking up and conjugating bilirubin, or we're not getting hepatocyte production of bile. So this is the most common form. In adults, we see this mainly associated with viral hepatitis, but you'll see on the next slide, it's so common because of the newborn form, which is a transient type of jaundice, which means it comes and it goes, but it does lead it to predominate these types of jaundices. in these adult, or it could be children too, when there's physical damage to the liver, either by infection, tumors, drugs, different chemicals that are hepatotoxic, you damage the hepatocytes and their ability to conjugate bilirubin or to make the bile. Again, you see this mild transient form seen in newborns, and it affects, 1 out of 2 newborns. And this is what a pretty high level of jaundice looks like in a newborn. So he looks a little cranky right there. I'm saying he just because I have 2 boys. It could be a boy or a girl. We cannot tell by this picture. But we see that the skin is yellowed and the sclera can be visualized as a little bit yellow too. So remember, bilirubin is removed through the feces. And what do you need to do to make feces? Well, you have to eat something, right? So newborns, upon birth, haven't been eating really in utero. They've been getting through the umbilicus, attached to the placenta, the nutrients and oxygen necessary to sustain fetal life from the mother. Once they're outside of the body, the sooner feeding is established, the sooner this transient form of jaundice goes away, because they will start eating, they'll start creating a feces, and then the bilirubin can be incorporated into the feces. Another important thing to remember is that these conjugation enzymes, so if you watch the first part, the introductory part, I said that some conjugation enzymes develop at different stages. So the conjugation enzymes necessary to conjugate bilirubin, they don't fully mature until about 7 to 14 days postnatal. And also remember that about 37 weeks is considered term. Pregnancies go about 40 weeks nowadays. So the sooner newborns are delivered, especially before 37 weeks, the more common it is to see this type of jaundice. So it's going to take a little while for these cells to mature, and it also is going to need to involve some feeding. So if there's any feeding difficulties upon birth, this will take a little bit longer to go away as well. You may have seen these before. These are referred to as bililights, short for bilirubin. And bililights, they're set to a very specific wavelength of blue light, which helps to clear the bilirubin from the body in a more efficient or expedited manner, faster than normal. This type of ultraviolet light is also available in sunlight, but this is a more concentrated form of just that wavelength. So even in mild transient cases when you don't see such extreme yellowing, if you even take 2 thumbs and stretch very gently, not hard, the skin of a newborn's belly, you can see sometimes yellowing there. And I remember when I had my kids, they would ask me to nurse in front of a window when I was nursing them because you're getting some of that ultraviolet light. Well, I was trying to avoid personal things, but when I was born, I had to stay in the nursery for a couple of days to be within these bililights because I had pretty severe jaundice when I was born. Nowadays, like my aunt is a pediatrician, she orders bililights to be sent home with newborns so that they can enjoy their first couple of days at home rather than hanging out in a nursery if it's unnecessary. So these just help to clear out and encourage excretion a little bit faster. They don't cure it magically, but they do encourage excretion rates. Okay, so that was hepatic jaundice or hepatocellular, and now we have posthepatic, which means something after the liver is producing the jaundice symptoms. This is also referred to as cholestatic, and this is referring to the gallbladder. So cola is referring to, like we saw, quinodeoxycholic acid. So cola is referring to bile and association with the gallbladder. So posthepatic jaundice means there's some sort of obstruction that's preventing flow of bile from the liver down into the duodenum. Generally, this is from an obstruction, most commonly due to a stone, but it can also be physical damage inside of the liver. We call that intrahepatic. So in the same way that we can have hepatocellular cells damaged from viruses, tumors, radiation, we can also have damage to the ducts themselves, which prevent free flow of bile. More commonly, we see extrahepatic, which means something outside of the liver is occluding the duct, either the cystic duct, the common bile duct, or the sphincter of Oddi. So a mechanical blockage, this can either be a carcinoma. We'll take a look at the pancreas in a little bit, but when you get a look at this, the pancreas is right overlapping with the outflow from the liver. So if there is pancreatic swelling, that puts pressure on the ducts as well and can cause obstruction. And then vice versa, when the liver swells, that can obstruct the pancreas as well because those ducts converge. And then you see this forming because of gallstones. We have some great gallstone specimens down in the gross anatomy labs. You can touch the gallbladders and actually move around the stones between your fingers. Well, hopefully wearing gloves. You can do it without them if you'd really choose, but they're really cool to feel. They're soft, they're squishy, and there can be quite a few of them in the gallbladder. And really, it's when they get lodged that they create these large issues. So here's one thing I want you to notice in this picture. This drawing is just showing you that there's multiple stones within the gallbladder. So first of all, remember your anatomy. We've got the liver up here, and this is the common bile duct, and this is the cystic duct coming from the gallbladder. So when these two converge together, they enter, again, the common bile duct. So this would be the common hepatic bile duct. So this is just the plain old common bile duct, CBD, common bile duct. When there is a stone obstructed in the cystic duct, I want you to think about this. Would there be jaundice? Good question. I gave you a second to think about it. So if there's a stone here in the cystic duct, would there be jaundice? So I want you to think about your anatomy. If this is our liver, and this is where bile is coming from, if the stone is up here, there would not be jaundice visible because there's still going to be the free flow of bile down through the hepatic ducts and the common bile ducts. If there is a stone in the common bile duct, so way up here, will there be jaundice? Yes, there will be, because we're not getting flow from the liver or from the gallbladder. In that case, that can mean that some things are normal, so juices will still flow from the pancreas, so there should be good bicarbonate excretion if everything is going correctly, which means you're not going to see ulceration. But what you'll see in this case is it's called steatorrhea. So diarrhea is water-rhea, like water feces. Steatorrhea is fatty diarrhea. So when there's a physical blockage within the common bile duct, but the pancreas is still maintained, so mainly you have bile salt insufficiency, there's pale, like yellowish stools. They're greasy, they're difficult to flush because you're not getting bile to emulsify the fat. Okay, the biggest damage is when there's a gallstone blocking this guy here, so the sphincter of Oddi, ampulla of Vater area, because both the pancreatic juices and bile will be limited. So there you're going to see damage and abnormalities of the pancreas, and you're also going to see difficulties with bile outflow. Both of those will be blocked. So this, you will have lots of problems, but you'll definitely see jaundice. But where you will not see jaundice is in when there is a stone impacted in the neck of the cystic duct, because there's still free flow through the common bile ducts. So let's talk about gallstones for a second. So gallstones are made out of cholesterol, and they are fine usually until they get stuck. And we call that an impaction, when they're physically impacted. They are made up of water, inorganic ions, bile salts, cholesterol, lecithin, and conjugated bilirubin. When somebody forms a lot of these, remember, bile salts are what is necessary to break down fats. So you can give them bile salts to help treat that. Also, another thing is we all have the same amount of bile salts. However, that can be overwhelmed in the case of a really high cholesterol diet. You can eat more cholesterol than you have bile salts to digest for you or emulsify. So 80 to 90% of these stones, they're just cholesterol. They're cholesterol, and the rest of it is these little leftover pieces. So there is some bilirubin in there. So you will see that they are yellow, they are squishy, they are soft, and here's what one looks like. So this was an excised gallbladder, so one that was taken out. When we talk about the formation of stones, it's called cholelithiasis. So a colectomy is the removal of the gallbladder. So in this case, this gallbladder was removed when there is a lot of swelling to the gallbladder due to impaction. The easiest thing to do is really just take it out if you can't sonicate the stones. All right, so the peak occurrence in gallstone production is women with a BMI over 35 and older than 40 years. And again, it can be due to an excess of cholesterol, so overwhelming the natural amount of bile salts, or a deficiency of bile salts because of liver abnormalities. Okay, so other things that show you that there's something wrong with the liver. So we said jaundice is easy because you can see it. Some other signs that the liver is not working correctly. So we've learned that vitamin K, it's vitamin K for clotting, right? It's so important in making coagulation factors that they named it vitamin K, a K for clotting, right? So when you see that there is difficulties making vitamin K into coagulation factors in the case of liver damage, then you're going to see lots of bruising, extended bleeding time. So there'll be coagulopathy, we call that. So a disease of coagulation. Also, one of the things your liver helps to do is make proteins when there is depressed protein synthesis. That's called hypoalbuminemia, low albumin in the blood. If there's not protein there to keep the water in the vessels, then water will go out into the body and cause peripheral edema. We also refer to this as pitting edema because when you put your finger into somewhere, usually around the ankles, it leaves a pit. And then there's a rebound of that skin, which takes a couple of seconds to bounce up. And then the number of seconds it takes is the grade that you give that pitting edema. So maybe it's +2 pitting edema, +4 pitting edema. So when there's depressed protein synthesis, you start to see pitting edema. So that's a sign that something could be going on with the liver. A pretty severe sign is hepatic encephalopathy. Encephalopathy means the disease of the brain, the encephalon. So liver-derived brain disease. One of the things that the liver is really important for is metabolizing substances. So those include things from digestion, drugs, etc. Proteins need to be deaminated. If they are not deaminated, then they become neurotoxic and they start to cause brain damage. Also, urea is where we store nitrogenous wastes, and we want to excrete that in the urine. But if we do not clear and deaminate these amino acid groups, then they accumulate in the body and they accumulate as ammonia, which is very dangerous for you and causes quite a bit of brain damage. When there is a mild development of ammonia, people just feel kind of tired, lethargic, the same types of things you see with any accumulation of a heavy metal. And then it can progress into full-on late coma scale things, so feeling disoriented, going into a coma, developing a flapping tremor of the hand called ecsterixis. Okay, improper drug metabolism. When there are liver abnormalities due to damage, you will see that the half-life of drugs is altered. So you will see things lasting a lot longer in the bloodstream than they're meant to. So people will be intoxicated a lot longer if they took an intoxicating substance, for example. If they took a cold medicine that causes stimulation, like Sudafed, instead of feeling ready to go to sleep a couple of hours later, they might be stimulated for 12 hours afterwards. So drug action is prolonged because there is not adequate liver function needed to metabolize those substances and then remove them from the body. So changes to dosing are encouraged for individuals with liver abnormalities so that we don't build up substances to toxic levels. Finally, something that tells you something liver-related is going on is hormone inactivation. So both Males and females have androgen. Women don't have testes, but they do have the adrenal glands making DHEA. And both males and females have estrogen. In males, estrogen is made by the gonads in the same way that females make it, but mainly it comes in the form of testosterone that is modified in the adipose tissue into estradiol. So those things have their own function in the opposite gender anatomy. However, what you need is a general inactivation of those so that we do not have, without desiring, the secondary sexual characteristics of the opposite gender. So when there is damage to the liver in males, for example, with very extensive drinking, you can see feminization of the tissues. So development of breast tissue called gynecomastia, lactation is called galactorrhea, and in females you can see masculinization of the tissue. So facial hair becoming coarser, the voice going lower, hair developing in other places in the body, and then loss of feminine features. So these are all signs that something is not working correctly in the liver. So there are some pretty good tells, clotting related, brain related, drug and hormone related as well. Okay, so I'm going to talk a little bit about hepatitis. And hepatitis viruses, they're named hepatitis because they all cause liver inflammation. There are a couple of them. In general, I want you to know they all cause the same thing. Hepatitis is going to cause inflammation of the liver, and the liver is in the upper right quadrant. When the liver is inflamed, there's nausea, there's vomiting. When you feel like that, you don't want to eat. There can be jaundice because the liver is not working appropriately, so there's not good bile production. There could be obstruction of ducts, fatigue, itching. These are all signs that there is hepatitis, and there can also be a possible pain in the upper right quadrant in the location of the liver. So this could be either acute or chronic. So there's a bunch of different types of hepatitis. My computer's not working right now. So these different cases can be autoimmune in nature. They can result from these various viruses. They can be due to other bacterial parasitic infections, and hepatitis can also be a result of poisoning, of overdosing, of medications, and of drugs of abuse. So in general, we've got hepatitis. Huge amount of things can cause it. We're going to first go through the different types of hepatitis viruses. But when you're studying, I would encourage you to come back to this slide because there's different types of hepatitis that can reactivate. There's some that can become chronic. There's some that go away. There's some you can get a vaccine for. And then there's some that cause huge amounts of death of liver tissue. So they have their own varieties. It's important to know that. All right, so we'll start with Hep A. Hep A is an acute and mild condition. Minimal intervention is needed. However, when there are outbreaks of Hep A in a region, they do offer Hep A vaccine clinics afterwards, free of charge for people who have eaten at that area, because this is the one that is going to be food related. Hepatitis A, it has an incubation period, so how long it takes to grow into a mature virus. It takes about 3 to 6 weeks, and this virus establishes itself in the liver and then makes copies of itself in cells. That's how viruses work. And then it passes through the bile into the feces to contaminate the feces. There are small, minuscule concentrations of hepatitis A in other bodily fluids. Its highest concentration is in the feces. So this is called a fecal-oral route of transmission. The most common cause of this is improper hand washing. So when you go to the bathroom, if somebody had a bowel movement, and you're supposed to wash your hands for a full minute afterwards and scrub everything. If you don't do that and then handle food, and there's hepatitis A in the feces, it's really easy to spread that on. So this could be spread mainly through improper hand washing, handling of food, sharing of food. There's usually large outbreaks, especially in the Buffalo area, when someone who works in a restaurant is affected, and then they're handling people's food. So when you're waiting tables, you touch all kinds of dishes, and that's just something that happens. And again, when that happens at different restaurants, they will announce it. They will say, if you dined at this restaurant between these dates, please come for a Hepatitis A clinic free of charge. And once you get a Hep A vaccine, the good thing about it is, like, now you don't have to worry about Hep A anymore. You can be prevented from getting that for life with the vaccine. So it's not something that reactivates. You get it and it doesn't come back again. Another thing that this can happen from is just contaminated water, so in things that hepatitis A live in. The reason there's shellfish on here is because shellfish definitely carry Hep A. If you think about where things like clams and mussels like to go in our modern society, they like to land on things, right? So they can land on boats, they can land on rocks, but when we think about really large storm drains or outflow pipes, that's a great place for shellfish to hang out. So if that's a sewage pipe, raw sewage is kind of flowing over them, and they don't know the difference. They don't really have brains. They're just kind of blobby things. That is why it's recommended that when people eat seafood, even if you really love raw oysters, it's recommended that they are at least steamed for a little bit, because if they do carry hepatitis A, then you have hepatitis A, and you're going to get all those symptoms that we talked about. Again, the good thing about that is you can't get a vaccine for it to prevent you from getting it in the future. And if you get the vaccine before the incubation period is over, it can prevent the emergence of those symptoms. So Hep A is the food one. Hep B is it's not fecal oral, it is everything else. This is generally more serious than Hep A. It still causes general hepatitis symptoms, but it's more likely to damage liver tissue at an extensive rate. However, signs and symptoms are mild in most cases of hepatitis B. It's present in all bodily fluids except for the feces. So hepatitis B establishes itself in everything, which means you can share it in a variety of ways. Blood to blood, sharing of needles, sexual contact, mother to child. And when I say share needles, that doesn't always have to be nefarious or somebody saying, here, use my needle, it's dirty, you don't need a clean one. In healthcare workers, that most commonly happens from a needle stick, and the most common cause of a needle stick is recapping needles. You are not supposed to recap needles. That is the most simple way to get pricked with one. You throw it in the sharps container, you don't think about it again. Sexual contact, all forms of sexual contact that are more likely to involve blood sharing will increase the transmission of any sexually transmitted disorder. And then vertical transmission is referring to mother to child, which can either be during delivery or in some cases diseases can be over the placenta, but usually during delivery. With hepatitis B, signs and symptoms usually go away after 4 weeks, and this can lead to immunity. In most cases it does. However, it can become chronic in a small subset of individuals. So I want you to notice something here. This might look kind of complicated. Don't get overwhelmed. It's a virus which has infected a cell. So V is for virus, V for virus. And this is an enveloped virus. So now we have like the DNA, we've got like this memory, whatever, like messenger RNA. And then we have this surface coat. And this surface coat is called HBsAg. One thing that's important about this is, well, one is that you can test for it in the blood. So that's how you figure out if somebody has Hep B or not. The second thing is not only is it not needed for more viruses to go out and infect other cells, we'll see on the next slide that there is an incomplete viral particle called hepatitis D. It's also called the Delta virus or the Delta particle, which is a cool, badass name. And the hepatitis D virus doesn't have its own surface coat. So what it does is use this HBsAg from hepatitis B. So here's what that looks like in animation form. So when there is a hepatitis B active virus, when it's already infected somebody and it's infecting cells and it's spilling over its surface coat into the bloodstream, Hep D, which is incomplete, it can't do anything on its own. What it needs is an active B infection in a host. And it piggybacks on Hep B infections and utilizes its surface coat so that it can borrow it to infect other cells. Hep D is really bad. Not only is it making this like poor Hep B in this picture kind of miserable because it looks heavy, but it causes massive, massive liver necrosis. So again, it's an incomplete viral particle, the delta agent or delta particle. It doesn't have its own surface coat. It has to borrow the surface coat from a Hep B. So that means somebody needs to be actively infected with hepatitis B in order to get a hepatitis D infection. So you see this more commonly when somebody has chronic hepatitis B. They can acquire then hepatitis D, and when that happens, there's a massive amount of necrosis, massive amount of tissue death from this. So this is more difficult to transmit because you need to have an active Hep B infection. Otherwise, it won't infect cells because it doesn't have the ability to do so. You see this most commonly among people who are sharing needles or who are having sexual intercourse that is involving blood sharing and more tearing. Homosexual male intercourse is more likely to involve blood-to-blood transmission. Anal intercourse in general, female to male, involves more blood sharing between individuals than vaginal to penile intercourse, and the lowest rates of transmission are female to female intercourse. Okay, so hepatitis D can affect on its own, needs an active B infection, very dangerous, very bad, massive necrosis. Then we have C for kind of the most common one, hepatitis C. Hepatitis C is caused by all the same things as B, so needle sharing, sexual contact. Vertical transmission is pretty uncommon, so mother to child. It's more difficult to transmit than hepatitis B, and there's no lasting immunity to this, which means people can get it again and again and again and again when they're in high-risk populations. 50% of people, so 1 out of 2 that are infected with hepatitis C, they make a full recovery. When nothing special happens, there's no like crazy stories. We call that unremarkable recovery. It's not to insult that person, like, well, there's nothing remarkable about them, but nothing special, unremarkable, nothing to write home about. It was pretty normal recovery. The other 50%, though, progress to a chronic and progressive disease, which means not only does it not go away, but it gets worse and worse and worse, damaging the liver. Finally, we have hepatitis E. Hepatitis E is similar to Hep A in that it comes from food. It's fecal to oral route of transmission. The only thing that's different is really where you see this spread. It is not as common in North America because it's usually associated with a lack of really stringent water purification. Not that that's always a great thing, but Western New York, for example, where we are going to school at DuVille College, has some of the most heavily treated water on the globe. So there's a high amount of chloride, of everything there. So when you don't have these huge water treatment facilities chlorinating water, it's more likely for Hep E to spread. So you see this in places without, those types of really intense sewage treatment plants. However, I do want to say that within the past decade, cases of hepatitis E have been found in neighborhoods within even New York City when there is a lack of clean sewage systems. So that is something that definitely persists in America and associated countries too, and it has to do with infrastructure and socioeconomic status. So again, it's similar to Hep A in that it's fecal oral, it's associated with food. Pregnant women are at real risk for getting liver damage from hepatitis A. E. Hepatitis E does not have a vaccine for it. The last I checked, unless something has changed drastically as of late, but it is something that can generally recur. The other thing I want you to remember about hepatitis viruses is that some people, they can get rid of the signs and symptoms, but they carry the virus with them forever, and that's called a carrier state. So you see some hepatitis B people carrying that virus around. 1% of the world population carries hepatitis C. So that means they're just carrying it around. They're not exhibiting hepatitis symptoms, they're just carrying it, which means when they have intercourse or share needles or share bodily fluids with people, they are sharing with them their hepatitis viruses. So in the carrier state, there's no active, like, outward signs and symptoms of hepatitis, but they can still pass it on. They can have minor problems or no symptoms, but they can spread it and spread it and spread it. Again, the carrier incidence is higher among individuals who are engaging in anal intercourse, using IV drugs, or infants of mothers with hepatitis B. I have Greg Ullman on here. He has passed away since I first made this slide. He had hepatitis C, and for years he was having intercourse with hundreds and hundreds of women, passing it on. He eventually had so much liver damage that he signed up for a liver transplant. The liver transplant was unsuccessful, so he passed away very soon after. So I want you to understand that that's something really dangerous. You're not just carrying this virus around, it's physically damaging the liver as you go along, and it's being spread to other individuals. And then sometimes, as I've mentioned, it can become chronic. So chronic hepatitis is just chronic inflammation of the liver. And it can be associated with these viruses. So like 10% of cases of hepatitis, they last more than 6 months. Sometimes it's idiopathic for that person. We don't know why it lasted that long, but it did. There's also chronic persistent hepatitis. So long periods of limited hepatic necrosis, so just small areas get killed, limited signs and symptoms. But remember, the liver is really good at regeneration. So a little bit dies, but then those can grow back and it goes away, and that's pretty common. However, chronic acute hepatitis is the type you see with like a Hep D infection superimposed on Hep B. That's really progressive. It can progress all the way to cirrhosis, which is scarring of the liver. And you see mortality rates as high as 50% 5 years after diagnosis. That means chronic acute hepatitis, 1 out of 2 people diagnosed with it will be dead within 5 years of their diagnosis. So it's a pretty severe thing that I want you to keep in mind. We want to limit this. Okay, some other things I want you to know cause hepatitis. There are certain drugs that are hepatotoxic. One of them is tylenol. So people tend not to think about that as a really dangerous drug, but acetaminophen, that's your Tylenol. Acetaminophen is very hepatotoxic in higher doses, and it becomes worse when it's added to alcohol. Alcoholics are at risk for that, meaning if they're taking Tylenol every day, that could cause that risk. But to be frank, this is way more common when people are taking things like Percocet, which is a mix of acetaminophen and hydrocodone or oxycodone. Lortabs are another example of mixed analgesic drugs. And the good thing about putting acetaminophen in with an opiate is that there's more pain relief, so there's less opiate that's needed. The bad side effect is that you can take a ton of opiate and not cause liver damage, a ton of it. However, you cannot take a ton of Tylenol and not get liver damage. So they're recommending now, the FDA has been recommending that Percocet and other mixed medications are pulled from the shelves so that we see lower rates of hepatotoxicity leading to cirrhosis and then needing a liver transplant among people who abuse opiate medications. So if we got rid of these mixed medications, it would harm the people who need them for pain and would hopefully use less opiate with the addition of your acetaminophen, but it would save a lot of money for the people going through liver failure because of misuse of mixed medications. The other really hepatotoxic drug is good old ecstasy. MDMA is its full name, which is methylene dioxymethamphetamine, MDMA. There was a new thing rolling around called Molly that the kids were really into. It was like a powdered form of MDMA, and it was like, oh, this is pure MDMA. It's not mixed with all the things that ecstasy is mixed with. After they studied that in labs, they found out that was not true. It's just the same thing that was in ecstasy, just marketed a different way. These drugs, they cause a lot of neurochemical weirdness, lots and lots of weirdness. We could talk about that later. but it's very, very hepatotoxic. These drugs are not meant to be used all of the time, especially every day, even every other weekend. That's too much. So, especially mixed with alcohol, you not only have a risk of death due to getting really hot and then running out of water to sweat with, which is called anhydrosis. So hyperthermia with anhydrosis is deadly. So if anyone ever asks you what the two most hepatotoxic drugs are in the world, you will know how to answer that. You will say acetaminophen, which is sold as tylenol, and ecstasy, MDMA. All right, so that was hepatitis.